All right, welcome back to the Elias Macko Show. Third hour of this program. You still got me for one more hour here. We'll take you through to noon. An investigation has been opened following the death of two patients in the crowded emergency rooms of Anna Laberge Hospital in Châteauguay. The two tragic deaths come at a time when doctors are actively deploring the deterioration of ERs in the province. The news of those two deaths, sent shockwaves through the health ministry, with Christian Dubé making a surprise visit to the hospital on Sunday. And of course, these deaths are coming despite the creation of a crisis unit a year ago by the health ministry. With more on this, let's go to Paul Brunet, patients' rights advocate, president of the Quebec Council for Patients' Rights, and he joins us once again. Paul, welcome back.
Good morning, Elias.
When you wake up, it was Monday morning, correct me if I'm wrong on the day, but when you wake up and you read the newspaper, you go on the web and you see the story, two deaths at Anna Laberge Hospital, suspicious here, and we know one person died in the waiting room. When you read that, what goes through your mind?
Well, I wonder how, we let an elder stay for 12 hours or more in the emergency unit without reviewing his status, because he was a status like number 3. But as we know, according to the literature, an elder being in a waiting room for that amount of hours should be reviewed, because his state of health will degrade dramatically if we don't review his status, and most probably get him in a more urgent status. So that's, to me, is the first question I have to ask. And I know there's an inquiry. We'll see what happens. But again, we let elders with probably some health condition stay for hours and hours in an emergency room, whereas, as we know, in Verdun, for example, we go and visit elders at home, elders who are sick, with physicians, nurses, to make sure that they're okay, and if they need to balance their medication or blood temperature, pressure, we equilibrate, and we take care of all those things before we are confronted to do emergency and then die on one and send everybody to the emergency. When are we going to stop that and start coming to visit elders at home? 25% of those emergency transportation are for elders who were not treated appropriately at home, whereas they could have been. And according to Verdun CLSC, we are saving 50% of hospitalization, 50% of bed, 50% of ambulance transport. We save a lot, but doctors don't want to go back at home care and visit their patients. They don't want to do that, according to a source that I've gotten this morning.
So that's what you believe is the pushback? The doctors who don't want to go back to home care? This is where you're pointing the finger right now?
That's the information I got from apparently the union of doctors, the FMOQ, does not want to talk about that. And I'm not surprised, because actually the money that a doctor gets when he goes and does home visits is much less than if he stays at emergency ward. But historically, Elias, a family doctor used to visit families, not sit in emergency. I'm not saying that they're not useful, but if we cut by 25% elders who do not need to go to emergency and take those doctors and have them move around to visit their patients, we don't need more doctors. We need better management of beds, and certainly of patients who need attention before urgent attention needed.
So we have in your estimation, we have the resources. It's how we're using those resources that's the key here.
Yeah. Well, listen, a lot of doctors' associations representatives are saying that we're lacking beds. We need more beds. Oh, that's fine. So that means that we're not lacking doctors. We're lacking beds. Okay, interesting. Well, I'm proposing that rather than adding more beds and more beds and more beds, how about treating the elder patients who could be treated at home in the comfort of their home, not in a crisis environment, and certainly be in a better situation before we need to transfer them. It is proven, Elias. I know that some people at the government level are agreeing. There's some blockage at the bureaucracy level, and there's a blockage at the FMOQ union for doctors.
So let me ask you this here, because you've been on this show many times.
Yeah.
You do not shy away from criticizing the government. Where you see a problem, you'll call it out.
Yeah.
But on this one, right, it certainly sounds like I've heard from the government, they're doing all these negotiations with public sector workers in various sectors, daycares and teachers and nurses and so many sectors. One of the things they keep saying, right, the word they keep saying is flexibility. We want more flexibility. We want more flexibility. It kind of sounds, with what you're saying about doctors in home care, that the government has a point. We have a problem here with unions who don't want to be flexible.
I agree with you. And, to some instances, according to the literature in management, yes, it is important in an industry focusing on care to a person. We need to be more flexible so that the people on the floor, on the local units, have more powers and can do what is needed in a given region or locality. But for that matter, I'm not sure that we're talking about the same flexibility.
Yeah.
If you're going to send a nurse from Lachine to Vaudreuil or Valleyfield because the government want and got more flexibility, I'm not sure that it is respectful for the nurse. But then again, we need, as we saw last summer, we asked some nurses group in given hospitals, hey, how about you guys decide and organize the schedules? Well, guess what? The results were that a lot of compulsory, overtime was needed. Why? Because the people who know what's going on, who know what is needed, have organized themselves. So the nurses organized themselves and got the solution, whereas the bureaucrat managers did not or could not reach.
Let's wrap up on this front, right? And back to the ERs, right? So, Quebec government created a crisis unit about a year ago, okay? And I remember hearing Christian Dubé saying, hey, they do great work in the ER at the Jewish General Hospital. Yeah. We're learning from them. We're going to bring some of their techniques across the system. Why haven't we seen a payoff? Why haven't we seen an improvement, keeping those things in mind?
What I'm hearing from the very high level of government is that there's a lot of resistance. Imagine resistance from the bureaucracy bloc, resistance in some localities, in some CIS and CIUS, where some of those PDG think that they own the place. So that's a lot of blockage, and you need a lot of guts to get. As a matter of fact, I submit very respectfully that Mr. Barrett had this kind of guts, but unfortunately for us patients, he didn't use the guts that he had towards making patient services better.
Yeah.
But that's my opinion, and I respect what he did. But that being said, he had the guts, and we need a lot of authority. So what Mr. Dubé is doing is, by Bill 15, transferring to a given corporation body the authority to push on the system and make it more efficient. I hope it is, because this is even the title of Bill 15, pour rendre le système plus efficace.
Efficace, yeah.
So if it's, if in 2 or 3 years you and I are still talking about what's going on and what's wrong, well, maybe we'll have to conclude some sad results about Bill 15.
Paul, listen, when you come on, it causes me to pause and think, and I think over the last few minutes here, you've made many of our listeners pause and think about the real problems at play here. We have to leave it there. Merci beaucoup. À la prochaine.
Thank you. Bye-bye.
That's Paul Brunet, patients' rights advocate.